Yeah, so I'm just going to start. This definition is end-of-life care, palliative care. The first thing is to just get a bit of clarity. I'm probably going to use these terms pretty interchangeably over the course of the next little while. But they do have somewhat different meaning. Now, I spent 15 years of my research career in the UK and 6 or so weeks in Canada. So I'm not absolutely certain how the terms are used in Canada, but in the UK, we use them interchangeably, but they do mean something. Palliative care is really about, I guess the simplest answer is like symptom management for people who are dying, or maybe not necessarily dying, but who we know are a life-limiting, non-curable illness. And they can spend a very long time receiving palliative care. End-of-life care is more about the care that happens at the end of life. It may or may not be palliative in intent. It may be curative in intent, but happens towards the end of life. Or it may just be other care that you receive. And then there's care that happens at the end of life, which is care you receive for things that are not related to your terminal illness, but did you get anyway. So somebody with diabetes may get care towards the end of their life, but we wouldn't necessarily call that end-of-life care, because they're just getting care for their diabetes. So if you have any questions about that when it comes up, I'm going to probably just mostly say end-of-life care. That generally is taken to mean to encompass palliative care, but not all palliative care is necessarily end-of-life, if that makes sense. So I just want to get that out of the way because otherwise it can get a bit confusing. Okay, so what am I going to talk about? So first of all, I want to just give some background. This is really helpful for me as an exercise to look at the context in Canada in particular. I'm going to talk about who and what matters at the end of life, and this is all in the context of economic evaluations. So when we do an economic evaluation at the end of life, who are we talking about? What matters? I'm going to talk about the value of treatment at the end of life. Particularly, I'm going to look a little bit at sort of high-cost therapies and things like that. I'm going to spend a few minutes, not a massively long time, talking about doing research with this population, some of the challenges we face, because there are some particular characteristics. And then I'm going to just have a little overview of what I think are some of the challenges facing us in Canada in particular, as end-of-life care, in terms of end-of-life care research from the economist perspective. This is more of a survey of end-of-life care research that I thought might be interesting, rather than a focus on a particular project or anything like that. So, although I will try and refer to work as I go along. Right, so this is right, the background. The audio's on, the camera's on. Sorry about that, folks. Okay, so that's not a laser pointer. Key fact that we've learned. So if you could put the slides back up, that'd be great. So I'm going to come over here and stand over and point to it. So if you can't see, that's 1977. So the year I was born, life expectancy in Canada and North America was between 70 and 75 years. Pretty much at the the top end of what was available in the world, except for those horrible socialist countries in Norway and Sweden, where obviously socialism gets you many extra years of life, unless you haven't read the paper yesterday from the Council of Economic Advisors on the dangers of socialism. Yeah. Anyway, sorry, my Twitter life. 38 years later, we've moved on quite a bit. In Canada, in many countries, Australia, most of Western Europe, 10 years of additional life expectancy in that time frame. So the population is really changing. We're growing older. 1962, this is where I would love the laser pointer. 1962, it says up at the top. This is the year Tommy Douglas and his Medicaid program in Saskatchewan, the first public payer healthcare program in Canada, was launched. That's the age profile. We've got a big baby boom. But look, the number of people in that top area, very, very small. Fast forwards to 2016, and it's a hugely different thing. Not only are there just vastly more people, but that profile has changed, and we're a much older, by and large, population. And if we project out into the future, that trend, it slows down somewhat, but it does still continue, and this rump of people up here, huge numbers of people. So that, you know, the way we think about resource use for end-of-life care needs to move on, because we just have a lot more people who need it. Never mind how many people there are available working to pay taxes to fund it. Huge numbers of people need it, and they need those resources. And we need those resources because as you get older, the cost of the healthcare you receive increases. So not only are there more older people, but as you get older, it costs more to provide care for you. Great. Having a lot more older people is great, because that means we've got a really healthy population, but we still have to figure out how to pay for the care that they need. We still have to figure out how to do that efficiently and equitably. So there it is. So the number of life years from 1990 to 2015 has gone up by 6%. The number of years of life with a disability in that time period has gone up by 11%. So more people, but they're getting older and they're getting sicker, more comorbidities. So that's just to sort of hammer home how important this is from a resource perspective. This takes up a lot of resource, and we need to look at it. Okay. So that's just a summary of those points. And that's a summary of those other points. But yeah, so this is what's happening. Okay. In Ontario, 10% of overall health is spent on people in the last year of life. So now we're talking about not necessarily age, but the last phase of life. So that's 10% of all healthcare spending. Most spending, if you look back at this graph, happens in the first year of life and then towards the end of your life. The last year of life, typically in old age, 79% of all deaths are in people 65 and older in Canada. So most people will die in old age and have palliative or end-of-life care needs. The leading cause of death in those groups is cancer and heart disease in people over 65. And those are illnesses that have definite palliative and end-of-life care needs. They're often illnesses that people live with for a good period of time, 6 months, 2 years, 5 years, depending on your condition. And they've been estimated in the past that 75% of people who will die will have palliative care needs. So in Canada, that's about 200,000 people a year. So you can see that's quite a lot of people. People who don't need these sorts of things are people who die from accidents, heart attacks, suicide. Those are probably the three biggest ones. There's things that can't be predicted, particularly. Most people, if you die with something like cancer or heart disease, you can predict that you'll need end-of-life care. So that's just the context. So that's why I care about it as an economist. It uses up a huge amount of our resource, and we need to make sure that we're getting the best value we can from that resource. Okay, so for those in the room or online who aren't economists, we're concerned with efficiency. We want to know how we get the best value from the money we spend, but we're also concerned with equity. And that's how fairly we spend resources. It's not just, oh, let's make sure we're efficient, but we also have to think about, is that fair to people? Is it fair the way we do things? Maybe not every economist is concerned with those questions, but I certainly am. So we have to ask ourselves, what matters to us as a society and as individuals at the end of life? What criteria should we use to allocate resources? And what are the challenges for making those decisions and conducting research and so on? There's a lot of people who have different views on this. End-of-life care as a topic in economics has not been around. It's not been on the radar for very long. But people have always done a little bit here and there, but it's increasingly of interest. And questions of what matters to society and individuals are definitely at the top or list of things that are still under debate, things that might be settled in other areas. If you saw Carl Claxton speak about a month ago, he said, health maximization is one of the goals, and that's true. But a lot of people think in end-of-life care that shouldn't be one of our priorities. So that's pretty settled in a lot of disciplines. But in end-of-life care, a lot of people are saying health maximization may not be what we should be concerned with. So I'm going to talk about that. So let's say we were talking about health maximization. What are we maximizing? Well, normally we talk about qualities if we're health economists. We're talking about quality adjusted life years. We're trying to maximize quality subject to various constraints, and one of those constraints would be equity or anything. But a lot of people say, well, in end-of-life care, we need to go beyond health maximization. We need something else. They might say, the things other than health we want to talk about. So there's a debate around, is it a welfarist framework or an extra welfarist framework? I don't want to get into that particularly today because it's a big debate. There's non-health outcomes. So I don't know if any of you have read Jo Coast's work. She's really interested in capabilities and going beyond health functioning, but the way that healthcare and other care improves our capability to live our lives. And we'll talk about that a little bit as well. Then we have to think about health budgets versus other budgets. In the UK in particular, the health care budget is separate from the sort of personal care budget. So you get health care from the health service, and you get social care from the social services, and they don't match up very well. So when I say social care, I mean things like people coming into your home to provide personal care, maybe to wash or clean or help you with your groceries or cooking, some sort of personal assistance, or even living in a care home. That comes from the social care budget, not from the health budget. So there's a lot of questions over if you're maximizing your spending from the health budget, should you include these care things, and then do you need to draw from the care budget? So there's a lot of questions around that. The other one, slightly out of order, I'm treating, but qualities. This is a big question. Are all qualities equal? And that's really an equity question, because as soon as we start to ask if all qualities are equal, that's an equity position in its own right. But a lot of people argue, and a lot of the evidence suggests that decision makers don't treat all qualities as being equal. Whatever we say as health economists, we could have a position as health economists or the community of health economists, but decision makers frequently have a very different position. And then we have to think about capturing distributional effects and cost effectiveness analysis, which is a lecture in its own right next week, 2 weeks from now at the Health Economist Study Group meeting, if you're going to be there. So I'll leave that from there. Okay, so what does all that mean? Well, if we're talking about maximizing health, most cost effectiveness analyses focus on a measure of health. We use the EQ5D to generate qualities, and we call that health, some sort of measure of health, or proxy for health. Okay, and the quality just combines quality of life and length of life. So can we use qualities for end-of-life care? Sure, why not? Most people probably instinctively say. But a lot of people, particularly Jo Coast and Charles Norman, have said, no, we can't do that. For a start, end-of-life care isn't about survival, so how can we talk about length of life? Well, it's possible because you can still improve quality of life through treatment without talking about extending life. So, okay, for me, survival is not a very big argument because you can still improve quality of life. And if you measure area under the curve, you have more qualities, and that's better. We capture the wrong domains. Well, yeah, but that's not related to the qualities, that's related to your measurement tool. So I'm just going through, their arguments, but they have some good arguments and some less good ones. Sure, if you capture the wrong domains, use a better tool. If the EQ5D isn't right, look at some of the other tools, develop your own tool if you need to. Stability of preferences at the end of life. This is important in the sense that people's preferences as they approach death change. What's important to people changes. This is actually related to this idea of the additivity of time. Time, it seems, has a greater value to people at the end of life. They'll give up everything. If you knew you were going to die tomorrow, you might be willing to spend a lot more on something today that you wouldn't otherwise spend. I'm going to go on a for a fantastic final meal. But if you just every other day you say, no, I'm not going to do that. So your preferences change, the value you place on other things changes. And in terms of time, that's very similar. But the objection to using qualities in this context that arises there is that I think is misplaced, because for me, these things are related to the individual's preferences, but not societal preferences, which is actually how we value equality, which is a societal value placed on a health state. So maybe the individual might place greater value in these areas, but society is talking about at the aggregate level. And then this is why death is an anchor when valuing states related to end of life. That to me is an interesting one. We ask people to do a time trade-off exercise at the end and say, well, if you're at the end of your life, how are they going to trade time and death when they already know they're going to die, or you've already told the respondents, you're at the end of life or something. So, but there's some really good work coming out at the minute around exploring other ideas about different anchor points for valuing time trade-off and so on. So that's actually something that's going to be empirical. So those are the things that other people have said. We can't use qualities. And I've sort of gone through my responses to those, and there's a couple of papers I wrote addressing each of those points, which I probably can't get into in any more detail now in the interest of getting through the rest of the material. But so I hope that's given some sense of the debate around qualities, the debate around what measure of health we use at the end of life. And the one that's sort of taken on the most interest in research circles as an alternative to equality, I'm going to show why it's not actually an alternative to equality in my view, is this idea of capabilities. So well-being as understood in terms of people's abilities and their opportunities to do and be what they have reason to value. So that's Amartya Sen and Martin Nussbaum's ideas about capability. So it's not about can I walk or am I confined to bed. It's about can I walk as much that allows me to go to places I want to go. Am I capable of going out of the house rather than can I walk or am I confined to bed? Does that make sense? And in end-of-life care, the instrument that's been developed is called the IceCap SCM. I can't remember what IceCap stands for, but the SCM is for supportive care measure. So that's the indication that it relates to end of life. There's the IceCap A for adults, there's the IceCap O for older people, there's IceCap SCM for supportive or palliative care, and there's an IceCap for children being developed in a minute. So we'll see how that goes. The argument is that capabilities can be used to generate qualities. Because according to Sen, capabilities are not a measure of utility as they capture non-utility information such as moral values, whereas qualities are a measure of utility, so they capture a different set of information, so that qualities are not possible from capabilities. And I haven't, this is a sort of new thing that I've been thinking about that I hope to write about in the very, very near future. In fact, I'm working on a draft at the minute. Where I would argue that actually a capability instrument can be used to generate qualities. And it may even be a better way of talking about measuring value at the end of life, but we can still then use it in relation to all of our other tools that we have. We can have some sort of translation between those. A capability quality versus an EQ5D quality versus an FZ6D quality, for example. So just to remind people, quality construction, we measure what matters to people. We give them an EQ5D or a tool, and we say, tell us about your health state. And they do that. And we get a health state, and this one is 1, 1, 1, 2, 3. Okay? And then separately, we've asked the public to tell us the value of each of those individual health states. We've said to the general public, if you were in this health state, and you could live in that health state for a certain amount of time, or full health for a less amount of time, which would you choose? And we get some values on the health state, how much people are willing to trade off. So for this health state, it's got a utility value of 0.442. And then we take some information about quantity of life, and we can generate some estimate of qualities for the person. So that's not controversial. I'm just trying to go through the steps that we use. So for me, that's fine. That means we can use capabilities, because the utility and the quality is not the individual's utility for a health state. The quality, the utility and the quality is public preferences over the set of possible health states defined by the tool that you've used to measure those health states. So the ICE-CAP and the EQ5D are no different in the sense that they have a finite number of possible health states, and then you can just establish preferences over those health states. In fact, they've done that with the ICE-CAP. They've gone and done some discrete choice experiments to get a list of preferences across those different capability states as opposed to health states. So we've got public preferences for different states, which reflect public utility or value for those states. So can we not then just say that that is the public view of those as equality? Now, I say this, and I want to write something on this, and I want to put it out there and see what people say back. The worst thing will be that nobody will say anything. They'll just leave it, not be ignored. So I have to write it in some way that would be really controversial. So I might get Chris's help for that.
What are you saying,
Anyway, so that's a little bit of a digression, but that's kind of what I'm thinking about right now in this area. Can we? I sort of agree that we might be measuring the wrong domains. I think that's a valid argument potentially at the end of life, and that we might want to measure other things. Whether the ICE-CAP SCM is the right set of domains, I don't know. But I do think that we can use qualities as a value, as a measure of value, and that we can then translate between different treatments to help bring the evaluation of end-of-life care into the same pool of analysis as other things, and we can start talking about it in those ways. Okay. So that's just to show the same process. This is the ICE-CAP A, I think. You don't need to read all that, it's just to show this. It's identical almost to the EQ5D in the approach you use. You get some measure of value for the individual states, and it generates some qualities. The only thing that's changed there is the measurement tool. Charles?
Yeah. When you say this, if you use a different approach to get the utility, can you compare with, for example, Endoflife? So when we value this,
yeah, I know what you mean. It's the same question that we've been asking about the EQ5D and the SF60 for a very long time. Yeah. I remember going to conferences 10 years ago, and every second paper was comparing those two things. No, they're not directly comparable because they measure and value different things. But I think there's got to be some way of having a sort of exchange rate. I think, we spend a lot of time doing mapping between individual individual outcome measures to try and generate these things. The statistical tools are there. We could probably come up with an exchange rate, an effective exchange rate. An EQ5D utility is equal to 0.9 of an SF60, but I've not really explored it in detail, and Paul Kine will probably tell me that somebody tried to do it and failed or something already.
Do you have any specific tool for dementia?
For dementia? So there are tools for dementia. There's the DemQual, the DemQual U, which is the version of that which can be used to generate utilities. There's, dementia isn't necessarily, it sort of falls under the mental health umbrella. So there's the new ReQual, Recovering Quality of Life in Mental Health tool, which may or may not be suitable. It's pretty new, so we don't know. The DemQual tools are not bad as far as they go, but they're good up until a certain point when a person with dementia still has quite a bit of functioning, and then once they get up to a certain stage of dementia, they lose a little bit of their. There's basically everything on them, you answer the worst possible score, and there's no way to get better. But they're not bad for that, and they're used quite a lot in the dementia research area. Right, so that's my views on can we use the quality at the end of life. Yes. There's not a lot of people arguing in this space. It's basically me and Joe Coast arguing against each other. And we basically did it because we sat in offices opposite one another until very recently, so we basically just talked about it rather than doing it in the literature. But I think I'm right. So there we go. Right, so are all qualities equal beyond health maximization? In the UK, NICE have a sort of implicit idea that equality is equality. Equality's gains, no matter by whom or in what context, are equal. And that's a pretty useful position to take, because then you don't have to think very hard about whether or not an intervention is indeed cost effective. But over recent years, people have started to talk about how we should be considering other factors in our decision making. So indeed, equality isn't equality. So that in the case of NICE, if everybody knows NICE, National Institute for Health and Care Excellence, I think it is currently. In about 2009, they introduced the end-of-life criteria, which basically said, for certain drugs, if the patient group meets certain conditions, we will use a higher cost-effectiveness threshold to determine whether or not we approve that drug. And they didn't say what that threshold would be initially. They left it up to the decision-making groups, the technology appraisal committees. But they said, you can go a bit higher, and then we'll sort of see how that works. So essentially what they were saying there is, equality is equality unless you're at the end of life, in which case equality is worth more to society than qualities generated for other patient groups. And over the years, the five sort of things that have come up have tended to be end of life, whether or not people have certain specific types of illness, cancer predominantly is the one that comes up there, whether or not a disease is a rare disease, and NICE's most recent position on this works out that they'll approve treatments for rare diseases in certain circumstances up to a cost-effectiveness threshold of £300,000 for quality. That we should pay a bit more for innovative therapies, and age. Age is one that comes up, and it's not an obvious we should pay more for older people or we should pay more for younger people. It sort of happens in a lot of different contexts, and I'll give a little mention of research. I'm not going to talk too much about rarity and innovation, just because they're quite complex in their own right, but I'm going to talk about the first three, because I know a little bit more about those as well. So better I talk about things I know than things I don't at this point. So a question of fairness, end of life, age, and having certain diseases. So the NICE end of life premium. So basically, if you don't know, many in health economics will know, but many might not. But NICE, like I said, they said if you're end of life and you meet these criteria, we're going to pay more for the treatments that are available to you. They didn't specify how much, but over the years, the appraisal committees made decisions. NICE went back and looked at those decisions and said, well, this seems to work out at about £50,000 per quality. So effectively, they've said the threshold now is £50,000 per quality for the end of life group. And that process was sort of introduced, in my view, as a sort of political stopgap to stop newspapers criticizing politicians and stop patient groups criticizing politicians for not approving high-profile cancer therapies. That's one person's opinion. I happen to think it's the correct one, and I think a lot of people would share it. Maybe not on camera for the internet to see, but there we go. And then, so first they introduced the policy, and then, in the best practice way we do things, people went out and tried to find the evidence to see whether or not this could be supported. So Kunal Shah has been doing a lot of this work at the Office for Health Economics in the UK. And he's found, actually, this probably isn't the case. People might give priority to patients with shorter life expectancy, but in his words, a non-trivial minority of respondents express the opposite preference. If your life expectancy is short, maybe you're not deserving of more expensive care, because, you know, how much more can we do? And that quality of life improvement was preferred over extension of life improvement. And one of the explicit criteria for the end of life premium to be applied is that there's an extension of life, and it makes no mention of quality of life. So, okay. Neil McHugh, Rachel Baker up at the Glasgow Caledonia University in Scotland. they've also been looking at this. And most respondents would give consideration to end of life only when treatments improved quality of life. Again, that's not included in the criteria. So this study challenges claims about public support for NICE's end of life guidance. So, yeah, so now we're in a place where we've got an approved approach to an approach to approving drugs that is pretty set and established, and manufacturers like it because it gives them 2 bites of the cherry. If the drug isn't cost effective, one of the standard things they can apply for end of life criteria. But most people in the public think that that's not a good use of resources, so it doesn't reflect necessarily very good value from the public's perspective. Okay, so that's end of life. There's a lot of research coming out now in that area, but they all tends to come to the same sort of answer. Sorry, excuse me. So then we come to age. So one of the first contacts I had with this was actually doing a review with Richard Ellen and Chris McCabe and some others on ageism in cost effectiveness analysis. And age is not necessarily about being end of life, but they're really intimately tied together, as I showed. Most people who die are in an older age group. So one of those approaches, one of the thinking was, what is objectionable about the unconstrained quality maximization, so a quality is a quality approach, is not that it involves discrimination on the basis of age, but on the contrary, it doesn't take into account age where it should. So, in fact, we should be discriminating on age in order to achieve equality as a quality perspective. Which is one approach. But then we get into, okay, well, if we're going to take age into account, how do we value age? Do we prefer young people or older people? A couple of reports said, identify this is quite new. This was recently a sort of argument against ever using QALYs in healthcare decision making, because QALYs place lower value on the lives of the elderly and disabled, because if you're elderly, you have less chance to benefit . I'll stop introducing the reputation of NICE. Right, okay, so back to well, if you go there, we'll see. Age. So yeah, I just wanted to say a couple of things about age. One of them is that the arguments often against age depend on this idea that we're worried about a total quality gain. Most of the time, we're worried about the incremental quality gain. We're worried about the incremental cost effectiveness ratio. So actually, if 2 patient groups, you're not talking about total quality gain of their lives, you're talking about incremental gains dependent on 2 different treatments. So we don't necessarily need to worry about age in most cases, unless age might be a criteria for doing a subgroup analysis. But again, the other thing is that the ideas around age are sort of all over the place. In Germany, they found little evidence that the German public accepts age at all as a criterion for allocating resources. GU did a review and found 25 studies looking at preference for age in doing economic evaluations. 14 showed the young were favored over the old. 8 had this inverted U shape, which meant that young people and older people were less important than working age people. So working age people should get the most, young and old should get less. So when we talk about age as a way to allocate resources, we have to be really careful because the evidence is pretty mixed on which way you should even do that, if you should do it at all. Sometimes we do think that age discrimination might be considered justified. There's this idea of the fair innings. So if you move with cricket at all, that's batsman has innings. He's been out there for a long time, and come on, we've had enough time. That's essentially it. If age comes out, a young versus old, there's this idea that the older person's had a fair and mistaken. The young person deserves a chance. But there's also this sort of opposite one, which is this kind of entitlement. I don't mean entitled as sort of entitled to that, but this sort of sense of having paid into the system, don't you deserve to get something out of it? Like a sort of Christmas pay in for the young person. So some people, I think age is one of the more complex areas. I don't think there's any easy answers. I'm just trying to flag up some of the different ways we go about it. And the easiest thing, generally speaking, in my view, is just equality is equality when it comes to age because of this complexity. And then having certain diseases. I've actually talked about this. I won't talk about this too much more. But the UK Cancer Drugs Fund has increased access to cancer treatment for patients for those who are cost effective. CADIT has the Pan-Canadian Oncology Drug Review. It's the only class of drugs that gets its own separate appraisal system. Otherwise, they're just reviewed under the regular drug review program. And access to palliative care. Cancer patients get disproportionate access to palliative care because the field of palliative care was established by someone, Cicely Saunders, who was essentially working with cancer patients. In the UK, most hospice patients, 80% of inpatient community hospice patients have cancer, which is much, which is disproportionate to the number of people who die with cancer. There's lots of other people who do this. In Canada, it looks like about 2.5 times as many cancer patients are in community and inpatient settings for hospice care compared to non-cancer. In long-term care, the ratio is better, but cancer is still more. But it is much closer to that. But in terms of community and inpatient hospice, there's a lot more cancer patients relative to the total population of patients who need care. So it seems that somehow, by design or by accident, equality isn't equality. Even if okay, so the value of treatment at the end of life. So you can't quite see this. That's the increase in drug costs recently and the increase in physician spending. The drug bill is increasing faster than any other area of spending in Canada. So these are from the National Health Expenditure Database from the Canadian Institute for Health Information. Many new drugs have very high costs, but have what I would say marginal benefits, which is the justification for those programs discussed earlier. And a really nice little review, that's really patronizing, sorry. A nice review came out recently, I didn't mean that. It showed, with a lot of cancer drugs, progression-free survival was used as the clinical measure of outcome and had absolutely no relation to quality of life. But what you need to get approved what you need for approval from the FDA for your drug is progression-free survival. So all you need to show is that people, there's not even overall survival, just people live longer with their disease progression, you can get approval. It doesn't matter if their quality of life improves or overall survival improves. So this is the thing I was talking about. So Chris and Prasad and the co-author did a thought experiment, and they showed that actually all you need to do is do a whole bunch of trials of inert therapies. Just correct me if I get this wrong. By chance, some of those will show a positive result. You get approval from the FDA, and you sell your inert compound because all you needed to show is progression-free survival, and you're done. So that's essentially what some people maybe do that. We might argue that a lot of the high-cost therapies, they effectively don't really benefit. Have a huge benefit. So just to show the president, show two survival curves, and then we can have a quiz. So one of these survival curves is from a quality of life focused intervention. So essentially using a patient-reported outcome measure to guide treatment decisions. And the other one is from an oncology drug. And we can guess which one is from which. It doesn't really matter which way you guess, but which one. Doesn't really matter. We don't have to put this, so I can't show the online people. So just say we're all like it. To me, those survival curves, especially when you get to the end, don't look massively different. This is progression-free survival for pertuzumab, and this is the PROMS outcome. And the PROMS outcome actually had a clinically significant survival benefit compared to standard of care, because it was using the patient's own views of their care. They think is the mechanism. It's more of a complex intervention, but they think that the patient's own views of their care have guided the right treatment choices, and so in fact they got better quality care from standard of care and standard of care. Compared to this drug, which ultimately, when you go out here, everybody progressed by the end of the trial. And the differences at certain points were statistically significant, but by the end of the trial, they were. This is obviously the one that gets the coverage, and this is the one that we get almost no coverage. And there's no mechanism by which we can even evaluate that in CABINET or NICE. They don't do reviews of low-cost interventions with many good quality. So that may have sounded a bit like an editorial, but that's just to raise debates. But actually, where is the value? Where's the value? Is it low-cost interventions like this, simple to implement? Or is it in these drugs? And maybe one day, if we keep doing this, we will get the innovative drug that actually does improve overall survival and quality of life and progression-free survival. So, yeah. So I may have sounded like I have strong opinions about that, probably, but it's really just to try and generate some debate around it. Okay. So the last few minutes, I just want to highlight something, which is the challenges of doing research in this area. We have challenges in doing research in every disease area, specific challenges. But when we're talking about people at the end of life, we have what I think are some particular challenges we don't get in some other areas. Some of them are shared, but they're all, so measuring outcomes. I talked about qualities, but actually we have a real problem here just practically getting information from patients. Patients are often lack capacity to give information. We know proxies can give variable information to have patients with their own quality of life. We know that different proxies give different information. Doctors value quality of life differently than family and friends, for example. So we have this particular problem with patients towards the end of their life often aren't able to give information. So how do we actually measure their quality of life? What are some of the alternatives? That's just that. Alternatives to quality of life. In the first bit of this slide, I've already talked about. But one of the really common measures used in research at the end of life is where a person died. Did they die at home, for example, or did they die in a place of their choice? Which is great to a certain extent, because quite often where people die doesn't matter what people say they would like to die. A lot of people say, I would like to die at home. I would not like a highly medicalized death. I would like family and friends around. And in the UK, some surveys show that about 2/3 of people want that, but only about 20% of people actually get that. But that's not a particularly good outcome measure. It doesn't allow us to trade off against other things from an economics perspective, but it does tend to be something that's used. It also doesn't reflect, I don't think, whether or not care is any good. You may have wanted to die at home, you may have ended up dying in pain, you may have had a good death in hospital, and that wasn't good. It's complicated. And something I've thought about in the past and still think about is processes of care. How do we care for people even when it doesn't improve outcomes? It's not that we ignore people. We don't say, right, we can't improve. If you can score 3 on the EQ5B and nothing you do is going to improve your outcomes, that doesn't mean we stop providing care. That would be unethical and inappropriate. So maybe there's something about the way we value processes, value things like making sure people are taken care of. It gets around some of these aspects. It's something that we haven't really got into it, but from a little bit of speculative thing. Defining the end of life period. This is actually really tricky. What is the end of life period? A lot of retrospective studies say, well, it's the last 12 months of life. So I had a student who did that, who took data from the administrative data set in the UK, the hospital episode statistics, and used the last 12 months of life before a person's death as the end of life. And that's really, really common. But you can't do that prospectively. You can't say, right, you're going to die in 12 months. And they have a question that they use in palliative care called the surprise question, which is to the doctor, would you be surprised if this patient died in the next 12 months? And if the doctor says yes, that's supposed to trigger a whole raft of conversations. Sorry, the doctor says no, I wouldn't be surprised. That triggers a whole raft of interventions potentially in the conversations about end-of-life care. But it's not very good. Half the people who they think are going to die don't, and half the people who don't think they're going to die do. So, and it's also, 12 months is also not a very good, it's not always appropriate. I did a study on the cost of cancer care where I defined the end of life period for lung cancer patients as 6 months, because the median survival, if you get diagnosed with lung cancer, is about 6 months. Some people will live longer, but most people don't get diagnosed at quite a late stage. With breast cancer, that period, median survival period, is about 12 months. It's just over 12 months, like 268 days. Great, so we can use it for breast cancer. Dementia can be many, many years. People can live with very severe dementia for a long time. And with palliative and end-of-life care, 12 months is just not going to cut it. So how do we do that? And that's one of the real challenges in defining end-of-life. Sometimes we can use a clinical definition like cancer staging to help us. That's great if the diagnosis comes at stage 4, whereas generally speaking, we're uncurable and treatment is palliative. Lots of cancers are diagnosed at stage 1 or 2, and we don't know when the transition is. But, and then 3.5, evaluation of complex interventions, missing data, and gatekeeping. These are things that are a little bit outside my area of expertise. I just wanted to flag them up. A lot of palliative care interventions. We've got drugs and we've got complex interventions. That's roughly what we do in that space. And a lot of interventions are complex interventions. Different ways of delivering hospice care, or so on. So we need the skill set to evaluate those entities, to understand what works. It's not a qualitative factor analysis. Missing data, as you can imagine, but we have a lot of data censored due to death, because the population we're studying, we expect a lot of them to die during our study. So how do we deal with that missing data? And there's a PhD student who runs the School of Hygiene who's looking at, I think, pretty much that question. If he's on track, he should be publishing or submitting his thesis in this. And then gatekeeping. Gatekeeping isn't, like I say, unique necessarily to end-of-life care, but in the practical terms of doing research, one of the problems that I've experienced is getting clinicians to allow to ask the patients if they would like to be too vulnerable. But then we don't know how to improve their care. So that's a real challenge. It's a challenging different areas, but there's a lot of things that's really problematic. I don't have a solution to that. And I'm just going to have the last few minutes. I've changed this slide color to black because I wanted to have some genuine scared quotes. So those are little ghosts around the rational. So, what next? What's happening? And it's really, I think, there's a lot of stuff around cultural norms that are the big issues. Assisted dying. So that's not something we have to deal with in the UK or have to deal with. Now I'm going to have to get my head around how this is going to affect cost control, healthcare budgets, I have a slide, and rations. Assisted dying. a report earlier this year, Canada doesn't have enough palliative care doctors to give patients an alternative to assisted death. So, and also we expect about 62,000 Canadians will request medical assistance to die in 2017 to meet their palliative care needs prior to that. Would require double the number of palliative care physicians working in Canada. So, yeah, assisted dying is going to have to, we're really going to have to rethink the way we deliver palliative care, and it's going to pose a challenge to people doing research when you're missing data censored due to death is because people have chosen to end their lives that way. Lots of complex ethical and moral issues and methodological ones which are much easier to focus on because we know complex moral ethical issues. But what are the implications? Staff training and skill needs. We can't train palliative physicians very quickly, so how are we going to deliver that care? What's that actually going to do to the drugs? If people aren't demanding these high-cost therapies which extend life for a bit, as they say, it's not worth it. I'd rather have a good quality of life and then decide when to die. What's that going to do to the drugs bill? It'll be interesting to see how that plays out and the demand for those kinds of therapies. How are we going to deliver all of that care? Never mind issues like we saw in the paper yesterday, so you might have seen about whether or not certain providers covered in health in this case would allow medical assisted dying to take place in their facilities. Well, how are we going to just deliver this really intimate and crucial bit of care for people? What does that mean to us as economists in terms of measurement and evaluation of outcomes? Clearly, people are saying, no, that's it. I've had as much life as I was. That doesn't, it's not easy to do. And then equity, this equity and access. People have the same right, irrespective of where they live, but actually, do they have access to those bits of care? If you live in a town where there's not the ability to provide that service, or too ill to travel, we have to go out into so. Lots of questions. Cost control. Canada is 7th in the OECD, 5% of GDP in terms of what they spend. That's been increasing. This is 2017, this is 1975. The trend is ever upwards, occasional blips. Where we get big jumps in percent of GDP is often big recessions, because healthcare spending rarely stops. We might trim it at margins, but it's the other parts of GDP that come down and make healthcare better. So we need to think about that. We need to think about conversations around the country about how we start to limit this process. I had this earlier, 4.2% of the rate of increase for the drugs bill, but also 3.4% in physician spending increasing at that time. Is that sustainable? Maybe we have to have some hard discussions with people who provide care and say, we can't carry on like this. You're going to price yourself out of the market because you just can't do it. So, drug costs, third highest per capita spending in the OECD. I don't know if you know, there's a review going on. About drug costs because Canada's pricing is tagged to American pricing, which totally inflates the costs we pay. So the review of that should be changed. So that would cost down, but other manufacturers going to accept a lower cost on it. So I don't know. We talked about moving care to the community, so may meet patient expectations for different place of death, place of care, and so on. Is that really expected to save costs? A lot of people think it will, but we've never actually explored it in depth, so I hope to be doing some work over that, using some of others. Rich data resources that we have available to us to answer some of those questions, and staff. In fact, not only are they increasing the physician and drug bill, but they're actually currently, according to IHE in your pocket, 2017, they're roughly equal in cost. So we talk a lot about the drug deployment. We don't ever seem to talk about the physician costs and rationing. So I think we need to have a conversation. This is a really hard conversation. It's taken, I think, the UK about 20 years to get their heads around this idea that we've always rationed care. All nice to make that process explicit for reasons of public acceptance and procedural justice. At least now you can see what happens. It can go some way to doing that, but I think there's a lot more. I think it's a lot murkier in Canada because Canada can review something, but that doesn't mean anything until the provinces decide whether or not to list the drug funding. And then private plans versus public insurance plans for pharmaceutical services and access to things. So, so there's a lot of discussion, I think, that needs to be had very publicly about rationing. That's my view, and I'm only been here back for 6 weeks or 8 weeks or something. So it's a slightly instinctive. I'm going to say instinctive. I'd like to think that it's not uninformed, but that's one of the things that we need to have those conversations. Yeah, and then so that's it. So it was a little bit longer than I expected. We did have a technical approach. Thank you if you come back online. So questions.
There's a question from Jessica online.
Oh right, where is that? How do I see that? What do I do?
In that chat.
In that chat box. All right. Okay, I can't quite read it. You might scroll up a bit.
Where it says, thank you for a great talk.
Sorry, can you read it out?
Okay, so Jessica Simon said, thank you for a great talk. I'm intrigued by the ICAP SPM. Meanwhile, I'm co-lead for PACES project. That's how you care early systematic impact of patients and health systems outcomes. Her question is, what do you think of that tool and others for measuring out-of-pocket costs? So they were referencing the
PSAFE tool. Okay, well, thank you for that. I don't have thoughts on the PSAFE tool because I am not familiar with it. So, yeah, sorry about that. I think it's important to measure out-of-pocket costs, especially if we start talking about things like moving care into the community, which may shift burden of cost from the healthcare system to the patient. If you're an inpatient, take your drugs. If you're not an inpatient, you might have to pay for your own drugs. So out-of-pocket costs is really important to capture. I don't know about the tool in particular. Any other questions online or in the room?
That's it from online.
That's it from online. And in the room, you all just want to go do the jobs. Yeah.
I guess, yeah, just out of interest for I'm not familiar with this ICAP, but I'm more familiar with like the EQ5D and SF60. But the EQ5D in particular has health states that are valued worse than dead. Of course, yeah, there's some issue with the time trade-off and that being used. What does that mean when you're looking perhaps at a group of patients that could self-report a health state, and then that value could come out as, society valuing their health state as being worse than dead? Is there any?
I don't think it makes it. I don't think that's a particular problem in end-of-life care research. I don't think that it's in any different way. Sorry, any different problem than it is for any other area. But again, that's where the sort of incremental analysis comes in. So it's not that they might start worse than death, and they might finish the study with a state worse than death. But we're interested in the change between those two time points, not whether they get above worse than death. But that's kind of one of the things that I'm thinking about when I think about medically assisted dying. For some patients, they may have health states worse than death, and that may bring them up to dead, in which case medically assisted dying is cost effective. And then we have to include it. But no, is that right? But in some cases, they'll actually have health states better than So this, I did a lot of sort of personal thoughts on this. It was a very good friend of ours chose to write this way about 10 days ago. So I've been thinking a lot about it. And you know, her quality of life, if you'd asked her to do the EQ5D, depending on which day you caught her, she'd get a really good score. But she still wanted to end her life in this way. So that's why I think medically assisted dying is a really complicated area for economists to think about in the way that we think about EQ5D scores. And maybe a capability score is better in that area. Maybe it makes no difference in terms of those issues. But I've only really just started reflecting on some of those questions. It makes it more complex. It's basically a socially sanctioned way of living. That's not normally what we think about. Yeah.
Just thinking, what can you do with unconscious patients?
With unconscious patients. Yeah, so this is where I think about processes of care, like patients who are unconscious or who are really incapacitated, so dementia patients who are really severe. They don't change their health state. So if you do an intervention, it's not going to look cost effective because you get no improvement in quality of life, unless you can bring them out of that state. So, but you still, that doesn't mean we don't care about what happens to them as a society. So some way of capturing the value that society places on the care they receive. That's really what the so I've thought in the past about measures of process of care and then valuing those processes, but that's not easy. And also, if you start doing that, you run the risk of sort of saying you must. You say, well, it's really important that patients they get that source. That matters for people who are unconscious for a long period of time. Well, how do you measure that process? Well, somebody that never returned a certain amount of time. But that is when they return, not that. Yeah, I did try, well, I did publish a paper. I'm not sure my thoughts were reflection. Yes, I think we can do something around processes. I just don't quite know how. I think that's the way to do it.
Can I just offer a suggestion
Yeah.
too, like for patients in the community who are in that situation, particularly if they are dying at home, where we all prefer to be. I think that an important measure in that situation is their caregivers' stress level, burden, etc. Because I think that that's a good indication of whether the care we as healthcare services are providing is good.
Yeah, so there's a lot of discussion, I think. I say a lot, there's like 4 people. But in the academic community, that's often a lot. There's a lot of discussion at the minute about carers and capturing care, quality of life, and our evaluations and stuff. And pharmacoeconomics, I think it was, this week or late last week published two opinion pieces on that. One by Chris, who dashed off, and one by Bruno Fowler about how can you incorporate that into quality of life. And then I've got something coming out in press on incorporating care, quality of life, within economic evaluations, and it came out this week. Yeah, so that could be some sort of, you could either use it as building it into economic evaluation or some sort of proxy measure that if they're getting good care, the carers are stressed, but then the carer might have to run. But it might be one way forward. And it's something that could at least be tested empirically. You could actually go out and test it and say, oh, actually, this is a really good proxy for possibly forward. Yes.
I'm actually with a patient organisation, and I've heard from a number of the caregivers where they receive no training to look after their family member. They don't know what to expect when somebody's dying. And I think there's a real gap there you might have the healthcare nurse coming in, but there's nobody sitting down with the caregiver to say, they may do this or they may do that. And they're at a loss. Then somebody dies and they wish they'd known that they should have seen something happening. They didn't know that the change in the breath meant the death was closer.
No.
You know, they're small, but they're huge.
Yeah, and I think that's not necessarily in the economics area, but in the palliative care research area, I think that some people are definitely, like I said, Laura Middleton in the UK has been looking at doing some research in exactly like training caregivers in particular ways. The ones that I was involved in was by training caregivers to do pain injections so that they could recognize the symptoms of breakthrough pain. They could prepare the medication and administer it under the supervision of a nurse who's on an iPad and looking. Because otherwise, you have to wait for the nurse. The nurse said, I can be there in 3 hours because I'm going to be with another patient and it's another patient. So that was partially about identifying that, like you said, people aren't trained for this sort of thing. Yeah, when you care for your kids and you don't know how to do it, you care for your parents, you don't know how to do it. Sure, why not? But there's a lot more complexities, definitely, for training people. And if we're going to talk about shifting care to the community, that has to be part of the package. Otherwise, you just create different demands on the formal caregivers that you could have met easier by having everybody in hospital rather than having the nurse drive around to 20 different homes. I absolutely agree. It's got to be part of any intervention in any policy has to take account of caregiver needs. It's not obvious. Yeah.
Have I got this right? There's a tendency to bias against the older age groups because they don't accrue many benefits over time. Compared to a young population. If you do an incremental analysis in the younger population and you do a lifetime time horizon, then when one intervention is better than the other, they can accrue quite a few benefits.
Yeah.
Whereas they're going to be censored. Those benefits can be censored due to mortality.
Yeah.
The older age groups. Is that not the fundamental problem here? When we're talking about when we're talking about cost effectiveness analysis for older age groups.
Yeah, I think it can. I think it can potentially definitely.
I mean, a lot of people are talking about like spillover, like collecting effectiveness data, quality of life. These are inherent in a lot of areas outside end of life.
Yeah, spillovers.
Yeah, it's all over the place.
But if you,
specific to this,
I guess, but if you're collecting that, if you're counting the qualities that accrue over lifetime, you also have to count the lifetime costs that people accrue as well. So, I think that intuitively to me that may even that, because then when you do your incremental analysis, you've got cross-selling on the qualities. Because quite often we capture the cost of the intervention now, and then we don't include lifetime costs, and we capture the qualities now, and we do include lifetime qualities. But I don't know for sure. Checking when you say makes sense, but I think
particularly for one-off cost, it's just a one-off cost that is participation.
yeah.
Children are going to even before we start talking about
Yeah, they do a lot of quantities, but then if you say the life, for example, or the other things, you then have to count the costs that come, the future healthcare costs as well as the future health benefits. So that's why I think it may not matter as much once you've taken into account lifetime health costs. But I can see that,
Yeah, I think that is an issue of quality of life. we have a lot of case. The people die in hospital, but cheaper than in discharge from home. Yeah. So, but when we incorporate the life there, that change disability.
I think age is probably the toughest sort of thing to think about in that sense. And that review that really Richard Edmond did, it's quite a long while ago now, but it really reviewed a lot of the sort of theoretical and philosophical literature on ageism in cost effectiveness analysis. And his conclusion was that it's not inherently ageist cost effectiveness analysis, but that's only if it's done in a certain way. You don't do it properly, essentially, you can definitely introduce an ageism problem. So it's hard to find. It's like a working paper from 2009. Well, it was a report done for the Department of Health because they were talking about introducing age as a protective characteristic and what the implications would be for things like that. And then there was a version published in Health Policy and Law or something like that, but it didn't get into the there was sort of more technical piece about how to make sure that if you follow this way, it will be able to do this way as well.
Yeah, I guess I had a question. I'm trying to wrap my head around. You show the results for progression-free survival, and with the PROM being used in sort of guiding the intervention versus usual care. And you mentioned how that's like a low-cost kind of intervention. But I'm just thinking more in terms of placebo effects more generally. Should we actually care about the value of placebo effects? Like if it's just about perception, or do we care about pharmacological, compounds versus placebo?
Do we care if they actually work?
Well, yeah, certainly something has a pharmacological property, but I guess how do you bring in the value of placebo effect?
You got lost in that thought experiment.
Yeah, no, we're not still talking about that. It's probably where you dipped out and come back in. No, I mean that's a good question. Like if we know something is a placebo effect, so are we ever going to prescribe a homeopathy or something like that? We know it's just water.
Mm-hmm.
So should we prescribe it even if patients feel that their quality of life is improved? Your nefarious pharma company just testing randomly compounds. They're not telling us that they're no, so we might believe them, we don't know. So no, that's what they're. But if we know it's already a placebo, but it doesn't improve quality of life, what should we do? Yeah, I don't know. If it improves quality of life and there's an incremental health gain and it's low cost, is that good? Doesn't have any impact on survival or progression-free survival, does it? So there are a lot of things. So I don't know. Yeah.
Just coming back, one of the things I think about, I'm an armchair health economist, so I'm certainly not that sophisticated, but one of
That's
the...
neither.
You've seen my office?
Love the lunch.
One of the topics that was triggering for me as you were talking is the perspective, right? So the societal versus healthcare payer perspective, and it seems in end-of-life care, particularly when we're talking about older people who prefer to be at home, and you're talking about community care nurses, and you're talking about this community care, which may not be a healthcare cost. So I just wondering your thoughts on because the CADIC guidelines are the public payer perspective is the Canadian guideline recommendation. Whether that's done or not, I don't know, or if there's exceptions made. So any comments you have about the societal versus the payer perspective in cost effectiveness analysis in this area?
Yeah, I mean, I think that's a question that's not just relevant to this area. I think there's good reasons for payers to want to take a payer perspective, because they get to make a decision of them. But I think it does a disservice. I think if you don't do a societal perspective and you know that there's just potentially pushing costs in other areas. So it's all well and good in the UK for the health system to say, well, we're going to do this, but you know that that's just going to impose a huge cost on the social care system. But that's their incentive, so they're right to do it from that perspective. And if they decide to do a societal perspective and say, oh, we are going to do this, but we can't afford it, then so I think it matters more in that's a problem that can be solved by two government departments coming together and having a conversation. I think it matters more if you're pushing the cost onto patients, that you need to take that into account. If you're saying this is cost effective, but only because of burden patients who then can't access the care that they need. Because we said, we're going to treat you as an outpatient, you don't have any costs, you don't have an employer insurance plan, you don't qualify because you're only 48 or any benefits. So you have to pay the whole cost of the benefit treatment or whatever.
And I understand externalizing the cost in that sense, but are there any benefits that would be missed in the analysis? I don't know.
From the society.
Yeah. So, you know, moving into community care that burdens patients, and you know, their caregivers are in community services that aren't maybe in the healthcare budget. But I was thinking about this: what benefits might be missed? You know, in other non-end-of-life care, it's like return to work early, and maybe there's like industrial or you know work revenue or you know production benefits. I don't know.
Yeah, I mean, if we include productivity costs in our analysis, we don't really recuperation. I'm not expecting that. Although some of them may be working part-time, depending on the illness that they have. But yeah, it's complicated. But then, do we not value people who aren't working for some reason? This is a question in cost-benefit and cost-effectiveness analysis of how do we value the time that informal caregivers spend. So, do we assume that their value is something related to their job, or what if they don't work, or do we assume that their value is how you do that valuation is actually something that people are spending a lot of effort trying to convince each other that that's I don't know the answer to it, but I know that if you don't necessarily include it and you say you're doing a societal perspective, you're not really doing it. Whether the societal perspective is doing it wrong. Christopher shares thoughts on caregivers.
Something correct for the actually when we do analysis from health safety perspective, we lost something. For example, if we consider for all the perspective from society, maybe we have to think of the quality of life from family members.
Right.
Yeah. We having started, my whole started with people considering, but if we consider we get a higher quality. That's
Right.
You know?
You're right. The challenge that then to interpret that result requires the cost effectiveness threshold of comparison is also estimated on data that includes those spillover effects. Otherwise, like we're using the wrong measure, we're weighing the height of something.
So, any more? Yeah, I'm going to say this will be the last one because I never thought we'd need an hour and a half, but we're almost up to that point.
So theoretically, qualities are equal, right? But because of how the funding arrangements work, they're not equal, and people who gain qualities from drugs have more value attached than people who gain qualities from social interventions or complex interventions like nursing. This seems like an area where that may be important, that you struggle to make a case for very cost-effective interventions because Is there a way to capture that and argue for those who implement it?
So you're saying for interventions that are like shown to be cost effective, we don't implement them, so we're sort of biasing against them even though they're cost effective. Whereas we go to great lengths to try and make sure we fund otherwise non-cost effective interventions.
The key, you could have a very, very cost effective nursing intervention that wouldn't be funded because there's no structure for that to be funded.
Right, yeah.
But a drug which was way less cost effective would be funded because there are incentives to fund drug criminalization. So you place less value on the people that are gaining benefits from the nursing intervention than you do the ones who get the drug. And in this kind of area, that's a particular problem.
I think, so, in a sense, the decision makers aren't you by not going, actually, we should do these. Let's do all of these cost-effective things first. You're right. I think they are sort of saying that quality of life getting it's not. We're not even thinking about it. So they are essentially valuing the qualities differently. But that's just a decision makers. But I know because they won't implement that policy eventually if it could be replicated then the results are robust. It looks like, hey, what a great way to improve people's quality of life. But that won't get widespread development because there's not a structure in place to do it, there's not a system in place to do it, there's not a lobby to say, big proms isn't out there, despite the efforts of the Apperson group. They're not out there pushing their proms, giving doctors free pens for using EQ5D and stuff like that. Sorry, cynicism taking over again. But so I guess I just want to say thank you, everyone. That's really, really interesting conversation. Thank you for sticking around. So maybe I have to do that every day anyway. I'm sorry. Thank you.